Hello everyone. Today we will be talking about an important topic for USMLE Step 2 CK. It's pretty high yield is hypertension in pregnancy. So our main topic here would be preeclampsia because preeclampsia is the most high yield. But we're going to just slightly touch on other hypertensive disorders so that you're aware of it and so that you don't get tricked on your exam. So that you can easily differentiate the other hypertensive disorders from preeclampsia. So let's start. So on this slide, we are going to talk about different hypertensive disorders that occur during pregnancy, and we're going to know how we can differentiate them on the basis of different of their characteristic features. So first, you should be aware that if the systolic during pregnancy is greater than equal to 140 and diastolic greater than equal to 90, that is considered hypertension. General is just hypertension. Then let's say that there is hypertension. There is a pregnant patient and there is hypertension, and it occurs at less than 20 weeks gestation, or if the hypertension is present in a female even pregnancy, before pregnancy, that hypertension is termed chronic hypertension. And remember, here we don't need any proteinuria, we don't need any sign of inner organ damage. It's just purely just hypertension that is present from before conception or at less than 20 weeks gestation. So this will be simply termed chronic hypertension. Then what if we get hypertension at greater than equal to 20 weeks gestation and there is no proteinuria or signs of inner organ damage? So it's basically similar to the above one, to the chronic hypertension, but it occurs at greater than equal to 20 weeks, but still there is no proteinuria or signs of inner organ damage, just like the chronic hypertension. So this is termed gestational hypertension. What if we get the hypertension at greater than equal to 20 weeks gestation, just like above in gestational hypertension, but there is proteinuria, either proteinuria or signs of inner organ damage? You just need one of these two. You don't need both proteinuria and signs of inner organ damage. One of them is enough. So if you have hypertension greater than equal to 20 weeks gestation and either of these are present, either of proteinuria or signs of inner organ damage is present, then that is termed preeclampsia. This is really high yield. This is high yield to know what constitutes preeclampsia, really high yield. And then what if you get preeclampsia? So the above scenario, the exact above scenario definition, like hypertension greater than or equal to 20 weeks gestation, and there is proteinuria or signs of inner organ damage, but it occurred at less than 20 weeks gestation. So what could that be? So that could be due to certain conditions that are really high yield for step 2 CK to know, to be aware of, and these are high IgG4 mol and antiphospholipid antibody syndrome. Another thing that I kept saying here, proteinuria. So we have to define what proteinuria is. How would you know in the question stem, in the vignette, what proteinuria is all about? Like what constitutes proteinuria? So there are either of the three things. So you need either of the three to know that the patient has true proteinuria in the preeclampsia range. So the 24-hour urine, if there is greater than or equal to 300 milligram of protein, 300 milligram per 24-hour urine. So if that is present, then that would constitute proteinuria. Or if that is not given, look at the urine dipstick for protein. If it is 2 plus or more for protein, then that is proteinuria. And even if that is not given, then you can look at protein to creatinine ratio, and if it is greater than or equal to 0.3, that constitutes proteinuria. Remember, in the question, they may give you like 200 milligram per 24 hours. That's not proteinuria. They can give you 1 plus on urine dipstick. That's also not proteinuria. So remember these values. They can trick you on these. It's common that they can trick you on these. So it's really high yield to know what constitutes proteinuria. So let's just briefly then talk about the pathophysiology of the preeclampsia. So normally there is a spiral artery that supplies the placenta, and it is usually really wide. At the bottom I drew here a wide spiral artery, and it has a lot of red cells just to represent it is a healthy blood flow. And if you look at above, at the picture above, I drew this placenta here, and it is really red, and the fetus is really big and it's really healthy. So the red means that it's getting more blood, it's getting healthy amount of blood. So, and then on the right, I drew the unhealthy placenta, the placenta with preeclampsia. And if you look at the bottom vessel, it is narrowed spiral artery, so it does not contain a lot of blood. And if you look at the fetus, it's really pale. The placenta is really pale. This is just to represent that there is a narrowed spiral artery, and it is causing a decreased flow towards the placenta and also to the fetus. So that's decreased flow can result in intrauterine fetal growth restriction, one of the complications of preeclampsia. Very high yield to know. Preeclampsia results in decreased flow to the fetus, and it can result in fetal growth restriction. If you compare the normal fetus, the left one to the right, which is the abnormal with preeclampsia, it is pale because it's getting less blood, and it's also smaller. So this is just to represent intrauterine fetal growth restriction. So again, so in the previous slide, we talked about we touched a little on the pathophysiology. So normally when there is a narrowed spiral artery, that results in decreased flow to the placenta, and in response to that, the placenta actually releases anti-angiogenic factors. Those anti-angiogenic factors can result in widespread endothelial dysfunction. And that endothelial dysfunction, that dysfunctional endothelium, is where the platelets bind to. Whenever there is an endothelial dysfunction or damage, platelets bind to that region. So widespread, there will be attachment of the platelet. The platelet adheres to the dysfunctional endothelium, and that results in consumption of the platelets. So that's the first thing. It will result in thrombocytopenia. Second thing, these microthrombi can reduce the blood flow towards the various organs, and it can result in organ dysfunction that we're going to talk about later. But third, it can cause hemolysis, and the reason for that is because as the red cells crosses these microthrombi, they can shear, and eventually they get really they get really fragile, and they can easily undergo hemolysis, and that results in hemolysis, hemolytic anemia. So let's just talk about the points that we talked about, the pathophysiology of the preeclampsia. So there is abnormal placentation that results in narrowed spiral arteries, that results in placental ischemia, and that ischemia results in increased anti-angiogenic factors, which eventually results in endothelial dysfunction, and that results in organ dysfunction. Then we have to be aware of two types of preeclampsia, and the one is a preeclampsia with severe features, and the other is preeclampsia without severe features. So in the next slide, we're going to talk about what constitutes preeclampsia with severe features. So if you want to know like what would constitute preeclampsia with severe feature, you just need to know in the question vignette, it's really high yield to focus on any of these features that I'm going to presenting in this table, in this slide. So if any of these features is present, one or more of these features in the question, it indicates that it is a severe feature. And why is it important to know preeclampsia with severe features and without severe features? Because the management is different. At the end, we are going to talk about management, and the management is quite different of these two. So what are the severe features? So first is the liver. And remember, all of these features occur, these organ dysfunction features, as I talked previously, because of microthrombi formation and the vasospasm. And the vasospasm also occurs because of the endothelial dysfunction. It can cause reaction of the smooth muscle of the endothel of the vessel, and it can cause decreased flow. So both microthrombi and the vasospasm decrease flow to these organs, and that results in organ dysfunction. So, for example, it can decrease flow towards the liver due to vasospasm. So that results. So you are going to look at the transaminases. Really high yield to know the transaminases. So if the transaminases are greater than 2 times upper limit of normal, that constitutes a high preeclampsia with severe features. That is one of the features that is present. Or they can give you clinically that there is severe right upper quadrant pain or epigastric pain. Another high yield point to be aware is that usually they ask in the exam, why is there right upper quadrant pain? And there is one thing that is really high yield to know is Glissen's capsule. Cannot emphasize it enough. It is important to know that the right upper quadrant pain is because of the stretching of the Glissen's capsule. So know that word, Glissen's capsule. Or they can say epigastric pain. So remember, these are all severe features. Clinically, they can say upper quadrant pain or epigastric pain, or on the lab, they can say transaminases are elevated 2 times upper limit of normal. So that's one. Or if they don't give you this, they can give you the kidney finding, AKI, acute kidney injury. So they can say creatinine. If you look at the creatinine and if it is greater than 1.1, that is a severe feature. And another, you can just think. And remember, this AKI is also because of the decreased flow. And they can give you platelets. So platelets, we talked about why they would be decreased because of the consumption, because they adhere to the endothelial dysfunction area, and that can result in their consumption. So if they're, and know specifically the level, less than 100,000, so that would be low platelets. That is a severe feature. Then if the systolic blood pressure is greater than 160, it's really elevated, or diastolic greater than or equal to 110, that also constitutes a severe feature. And then other features like any CNS finding, like stroke or severe headache or visual symptoms, these are all severe features. And then pulmonary edema, which I drew the last one, is also a risk. Is also a severe feature. So if you have any of these, one or more of these in a patient, you have to really pay attention to these features. So if they are present, you're going to treat it as preeclampsia with severe features. So like I said, these all features of dysfunction are due to two reasons. Number first is the vasospasm. Number second is microthrombi. Both of them decrease flow to the organs. So now let's shift gears and talk a little about risk factors. So what would be the risk factors? So remember, the first one that is really, really important to know is past history of preeclampsia. If in the previous pregnancy, the patient was having preeclampsia, there is at least 6 to 7 times increased risk that the patient is going to have preeclampsia in the current pregnancy. So these risk factors are important to know because they are going to give you these risk factors in the question vignette. So these are really important to know. Number second is obesity, BMI greater than or equal to 30, and it's important to know these. And in order to know these, I drew here a lot of fast food like the burgers and pizza, just to remind you of obesity. So this is also important to know. And remember, maternal comorbidities are also risk factors. These include CKD, diabetes, chronic hypertension, and we know that these fast foods are also risk factors for diabetes and chronic hypertension. Then nulliparity, so if this is the first pregnancy, it's also at risk. Then advanced maternal age, if it is greater than 35, if the maternal age is greater than 35, so pay attention to the age of the patient in the vignette. If she's presenting with hypertension in pregnancy, that's also a risk factor. Then multiple gestations is another risk factor. So if the fetuses are 2 or more, that is a risk factor. And if the patient does not have any preeclampsia in the previous pregnancies, but if there is a family history of preeclampsia, that can be a risk factor as well. So let's touch a little on the complications, which are really high yield to know. The first is the HELP syndrome. So H is for hemolysis, and we talked about why hemolysis occur, because the microthrombi, the red cells shear as they cross the microthrombi, their membranes get weak and they get fragile, and then eventually they undergo hemolysis. The E and L is for elevated liver enzymes, again because of the decreased flow, because either to do microthrombi or vasospasm. The word vasospasm, I'm saying it over and over again, it's high yield, because they will present you the case of preeclampsia, and they obviously wouldn't say that it is preeclampsia, but they're going to say what is the mechanism by which the enzyme levels are elevated, or why there is right upper quadrant pain where the liver is situated, or why there are other organ dysfunctions like AKI creatinine greater than 1.1. So the reason for all of these is either vasospasm or microthrombi. So look for those options, and pick them. So elevated liver enzyme again is because of the decreased flow, vasospasm, microthrombi, and then L and P is for low platelets because of the consumption. So that's because of that is for low platelets. So that is the HELP syndrome. It's one of the complications, and it is a severe feature if they are present. Then intrauterine growth restriction, very high yield. I touched on that in the beginning, and I'm saying this over and over again because it is very high yield to know, and it is asked over and over again in questions of USMLE Step 2 CK. Another could be stroke, and the reason for this again is due to vasospasm or microthrombi reducing the flow towards the brain. Pulmonary edema is another. It can cause pulmonary edema, and the reason for this pulmonary edema is because there is vasospasm. When there is vasospasm and microthrombi formation, that can result in increased hydrostatic pressure, and that increased hydrostatic pressure will push the fluid out into the alveoli. That results in pulmonary edema, and placental abruption can also occur. Again, because the vessels are involved, so any vessel abnormality may cause placental abruption. Also, because of the vasospasm, right? Anything that causes vasospasm will reduce flow towards the placenta, and that can result in placental abruption. For example, smoking can cause vasospasm, cocaine can cause vasospasm, and both of them are also risk factors for placental abruption. And then ARDS, again, it can cause bilateral pulmonary edema, which can progress to ARDS. So then the final slide, we are going to talk about management. So in management, remember, the most important thing that you should pay attention to is the weeks of gestation. Weeks of gestations is important. So if it is greater than or equal to 37 weeks, it does not matter now if it is with or without severe features. If it's preeclampsia and greater than or equal to 37 weeks, you are going to go and deliver. You're just going to deliver. That's the only management option. But if it is 34 weeks or more and the patient has severe features that we talked about, any of the severe feature, deliver. Then you deliver. Then obviously you are going to use antihypertensives to stabilize the patient, to decrease the blood pressure up to the 37 and 34 weeks mark. And for that you can use labetalol. And remember, you should avoid it in asthma and bradycardia. So in the question, always look for if the patient is asthmatic. If the patient is asthmatic, avoid labetalol. If the patient is, and also look at the pulse of the patient. If the patient is bradycardic, let's say 45 is the pulse, then you're going to be avoiding labetalol. And the reason for this is because labetalol is both alpha and beta blocker, and the beta blocker effects can worsen asthma and can worsen bradycardia. So that's why it can result in heart block. So that's why you should avoid labetalol in this patient population. So always, it's really hard yield to know to look for these features in the question stem. And I put a syringe here just to remind you that it is IV. Labetalol is given IV. Another option is hydrolazine. So if labetalol cannot be used due to contraindications, we can use hydrolazine. It is also IV. And then another option is nifedipine if the patient wants oral. If you want to prescribe oral, then it's nifedipine. And remember, if it's preeclampsia with severe features, you are going to be using a magnesium sulfate. So don't forget to use magnesium sulfate, and it is to prevent seizure prophylaxis. And remember, the first step is always maternal stabilization. followed by delivery. So don't be fooled. So if you get 37 weeks, don't be tricked, because if they say 37 weeks and if the patient is really unstable, obviously the first step should be maternal stabilization. And after that, you are going to deliver. Don't just directly pick delivery. First, you need to stabilize the patient. So this is going to be all for preeclampsia, and hope I've covered all of the high yield topics in this lecture and in this video, and I hope they are going to be helpful for you in USMLE Step 2 CK.